Hello and welcome to Module 4. In this module, we will cover the topic of preventable death panel reviews. As with the previous models, the information in this presentation is largely based on the Guidelines for Trauma Quality Improvement Programs. On your screen, you will see the website where this document may be retrieved. The core learning objectives for this module are to provide a basic understanding of the following: the basic principles of preventable death review panels, constituting the panel, how to prepare and present data to these panel members, and specifics of case review process. This section describes how to undertake successful preventative death panel reviews. Panel reviews are one of the simplest and most straightforward methods of trauma QI and require minimal resources. Panels review trauma deaths from a hospital or a region to decide by consensus if the deaths are preventable and if care could have been improved. Some examples of preventable deaths are deaths that occur from airway obstruction or from isolated injuries to the spleen, both of which are eminently treatable in most any location in the world. I would like to emphasize that preventable implies medically preventable. That is, the patient's life could have been saved by better medical care. In this case, preventable does not imply preventable by safety features such as seatbelt. Panel reviews have been shown to be an effective means to improve functioning trauma care systems, especially in regards to rapid transport, early assessment, appropriate surgical interventions, and fewer deaths from preventable causes, especially hemorrhage and airway obstruction. Conducting a successful preventative death panel review includes determining how to constitute a review committee, what information is necessary, how to collect, collate, and distribute this information, the specifics of the individual case review process, and the process of documenting the final discussion and analysis of each case. The preventable death panel review was one of the earliest techniques used to assess the development of a trauma system. The method is still one of the simplest and most straightforward techniques and requires minimal resources. Preventable death panel reviews are extremely valuable and have the advantage of not relying on extensive data collection and complex analysis techniques. The goal of these reviews is to combine data that are relatively easily accessible in order to assess whether any potential improvements in either the system or the clinical care could prevent the mortality. Data for preventable death studies can come from multiple sources, including the following: hospital records, pre-hospital information, highway patrol, safety, traffic data, and police records, death certificates and autopsy reports, as well as direct statements or interviews with care providers involved with each case. Important aspects of the case review process include selection and training of the panel, organization, timing, and location of the review meeting, and judgment criteria for the panel, as well as record keeping. All preventable death panels should have a chairperson responsible for leading and organizing the case review process as well as the meeting. The chairperson must understand all phases of care for the trauma patient, have a broad perspective, remain unbiased, and have the organizational skills to lead the panel through productive discussions that are enthusiastic and probing, yet non-confrontational and productive. Members should maintain an environment of respect as well as an honesty regarding the suboptimal outcome of death. They must share the common goal of improving future care through the often challenging process of critically assessing each death. Panel selection needs to be approached thoughtfully. A multidisciplinary panel has been shown to be extremely beneficial for adequate analysis of the data. A panel should be multidisciplinary with personnel from all aspects of care process, including pre-hospital systems and the various areas of care throughout the hospital, such as the emergency department, the operating room, and wards. This panel should meet routinely at fixed times in a neutral setting, and have members selected based on willingness, commitment, and their availability. If the reviews are part of an ongoing trauma QI process, the panel should meet routinely at fixed times in a neutral setting. Depending on the volume of a hospital or trauma system, the preventative death panel could meet monthly or quarterly. Less often than quarterly is not ideal. With careful attention to the composition of the panel and appropriate preparation, preventative death panel reviews can achieve levels of agreement approximately 90% of the time. This slide shows examples of preventative death panel participants. They include pre-hospital providers, emergency department nurses, emergency physicians or general doctors involved with trauma patients in emergency department settings, surgeons involved with trauma care, including general surgeons, orthopedic surgeons, traumatologists, and other as locally appropriate, anesthesiologists, neurosurgeons if they are available, pathologists or forensic medical expert or a coroner, radiologists if there are x-rays or other radiologic studies that are related to the cases being discussed, as well as nursing staff from the operating rooms or intensive care units. The panel chair assigns the responsibility for each case to be discussed at the panel review meeting to a panel member who is not directly involved with the care of the particular patient. Assignment of an uninvolved panel member is essential so that he or she can present an unbiased picture of the events as well as the records. The panel member reviews the summary abstract and relevant data source in advance and presents the case and data relevant to the full panel at the meeting. Members of the panel responsible for reviewing and presenting a patient chart at the meeting should be provided with copies of the summary abstract and a full copy of the relevant data sources to be reviewed at least 1 week in advance of the scheduled meeting. The chair of the preventative death panel usually reviews all the data sources in advance of the meeting. A wide variety of data sources may be used. Normally, the chair or a designated assistant compiles written abstracts summarizing the details of each case. Data such as the demographics, admission vital signs, and other information that is appropriate or available should be included in this abstract. The summary abstracts are then provided to each panel member. A standardized form can be useful for gathering and summarizing the data and for writing the abstract. Components of the summary of preventive death review include demographics, the mechanism of injury, the patient's transfer status and mode of arrival, pre-hospital and field vital signs with exact times, the vital signs on arrival to the emergency department, again with exact times, the Glasgow Coma Scale on the patient's admission, any procedures performed including advanced airway management, such as endotracheal intubation or other operations, as well as the injury severity score if it is available, and the probability of survival, again if available. Key time variables that need to be reviewed include the estimated time of the injury, the time until arrival at the scene from pre-hospital care providers, the time of arrival to the hospital, the time until transfusion of blood products, the time of the general surgeon's evaluation, and time until disposition to the operating room, intensive care unit, or ward, or the time of death. The panel member designated to review the patient's records in detail and present the relevant data to the panel is provided with the most comprehensive data. The remainder of the panel members usually only have the summary or abstract for review. In cases where particular components of the chart provided particularly interesting information relevant to the case, copies of those data may be attached to the summary abstract handed out to all panel members. For example, the pre-hospital information sheet might be provided on a patient with a prolonged transport to the hospital, or the emergency department data flow sheet might be provided on a patient who, on arrival at the hospital, was hypotensive secondary to a splenic injury but was taken to the operating room in a delayed manner. It is helpful but not mandatory to provide each panel member with a structured case review form on which they can indicate whether components of each aspect of care are felt to be adequate and timely. To maintain confidentiality surrounding the patient's information in an effort to keep the written documents as anonymous as possible, specific identifying data, such as a patient's name and/or a hospital record number, should be deleted from all the documents distributed. A code number or other means of keeping track of the case can be assigned to the paperwork rather than the patient-specific information. Panel members should receive a formal orientation during which expectations are set. Panel members responsible for presenting cases at the time of the panel meeting should receive full copies of the de-identified data sources at least 1 week in advance of the scheduled meeting. The panel chairperson leads the meeting and guides the discussion and the decision process for determining whether the death was preventable, potentially preventable, non-preventable, or non-preventable with care that could have been improved. The last item, or non-preventable but with care that could have been improved, may also help to identify opportunities for improvement in the system, even if the particular death in the question could not have been avoided. Some panels do not create a category for non-preventable deaths in which a care could have been improved. These panels use preventable, potentially preventable, and non-preventable as categories. Nonetheless, even with deaths that are deemed non-preventable, it is best for panels to continue to identify problems in care and to use this information in the development of corrective action plans. This is true whether 1 or 2 categories of non-preventable deaths are used. Using the full 4 categories is optimal and requires only minimal extra work compared to using 3 categories. Whatever classification system for preventability is used, it must be clearly communicated to the panel members. A standardized case review form to assist the members in keeping track of their critique is useful, although not mandatory. After discussing a case with contributions requested from the entire committee, guided by the chair, a vote on the preventability status of the death is taken. One school of thought suggests that the vote should be taken in an open fashion. This is done so that the members can discuss why they decided on a specific classification and to promote optimal discussion in order to achieve a thorough analysis and consensus. Other chairs and committees feel that ballots should be cast in confidence to avoid peer pressure and hurt feelings if care providers are in the room. This decision must take into account the composition of the preventable death panel as well as potential cultural and political implications of closed and open voting. There are 2 philosophies regarding the participation of doctors and other care providers who are directly involved in a particular patient's case. One theory is that the provider involved in taking care of a patient who died should not participate in the panel. This is based on the concern that the presence of that provider may suppress productive conversation and critical analysis of a case and therefore introduce bias into the ultimate judgment as to whether a death was preventable or non-preventable. A second theory supports the active participation of a provider involved in the care of the patient. The involved provider must be treated with respect. The provider may often be able to supply information critical to understanding a mortality event and may assist in identifying areas for improvement that might not be recognized otherwise. The decision whether to include or exclude a practitioner must be made by the Preventable Death Panel chair and will often be based on the culture of a hospital or environment and the number of clinicians who are knowledgeable and able to contribute to the critical review of the trauma death. In smaller hospitals, the limited number of staff available may require that all providers involved or not involved with a trauma patient's care should participate in the discussion. Whoever attends, it is clear that the critical chart and data review should not be assigned to the treating provider. An objective chart reviewer is essential for discerning the most pertinent and reliable information on the specifics of a patient's care. Although the treating clinician can be involved in the discussion of the facts, he or she should not be assigned the responsibility for collecting and presenting the facts to the panel. This slide reviews clarification of types and sites of deficiencies. Possible deficiencies to consider including the airway, hemorrhage control, the chest, fluid resuscitation, delays in treatment, and also documentation. The location of deficiencies to consider include pre-hospital, the emergency department, the operating room, the intensive care unit, the medical ward, care during the interfacility transfer, and system inadequacies. Adequate records of the patient data and the abstract provided to the panelists must be kept. Minutes documenting the panel discussion should also be recorded. At the conclusion of the discussion, the panel chair should be responsible for filling out the summary form detailing the panel discussion and the decision. Any recommendations to improve care, as well as communication with any outside agency, should be documented. For example, if an ambulance service brought a severely injured patient to a small clinic where the patient waited for hours prior to being treated or being transferred to a major hospital, an area for improvement is identified. The panel chair might suggest the corrective action for educating the ambulance providers and implementation of a formal policy to take injured patients only to a larger specific hospital rather than the small clinics. A formal letter that suggests this policy could be written by the chair would serve as documentation of efforts to improve pre-hospital care. In summary, preventative death panels are a versatile and widely applicable method of trauma QI. They represent the next step beyond the M&M conference. However, they have their limitations. One-time or even intermittent preventable death panels should not be seen as a substitute for a formal trauma QI process. They should be viewed as an extension of the standard M&M process rather than a replacement for it. During these reviews, you should focus on the determination of preventability. The assessment of preventability often depends on the resources and capabilities of an institution and/or system. Although preventability judgments may be viewed as somewhat subjective and there may be variation in reliability between different panels' assessments, death panel reviews are nonetheless a straightforward method of accomplishing the goal of assessing and improving the quality of care. Preventative death panel reviews are applicable anywhere in the world, in countries at all economic levels, and in both hospital and system-wide settings. The basic materials for a successful preventative death panel are available in any setting that cares for patients. The commitment of enthusiastic and intelligent panel members, the timely distribution of data sources reflecting a patient's course, and an interactive discussion of the panel members can assure the success of the panel. Thank you for attending Module 4.